What's the worst possible thing that a hacker could do? If you rewind 2 years ago, what was dominating the headlines at that time was many of these retail breaches. And we said the story's bigger than credit cards. And pretty quickly we dialed in on the worst thing that an attacker could do would be to kill somebody. That day we started this research.
Hi, I'm Joan Goodchild, Editor-in-Chief of CSO, and welcome to another edition of Security Sessions, where we talk about trends and topics important to security managers. Today we're going to be talking about hospital security, and I'm joined by Ted Harrington. He is with Independent Security Evaluators. Thanks for joining us, Ted.
Thank you for having me.
What can you tell us about ISE to start?
Sure. So Independent Security Evaluators, we came out of the PhD program at Johns Hopkins in 2005. We perform security assessments and security research for companies who want to understand how they'll be attacked by sophisticated adversaries.
So you recently concluded some research into hospital security and other healthcare-related venues and identified some pitfalls and shortcomings. What can you tell us about kind of the takeaways of that research?
Sure. We spent 24 months investigating 12 healthcare organizations across the United States, and we were studying to identify the premise: could an attacker harm or kill a patient in a healthcare setting? That's exactly what we found. We found not only that it was possible, but that in many cases it was actually very easy.
And so you weren't looking necessarily at patient data in this too, or was there some research into the securing of records as well?
One of the primary takeaways of the entire research boiled down to the fact that healthcare organizations today, and I'm talking about the business of healthcare, not the way a physician approaches a patient, but the business of healthcare today is focused heavily, almost exclusively, on protecting patient data, and has almost no emphasis on protecting patient health in a cyber context. So ultimately what that means is that organizations who would attack in order to compromise patient records, they're going to have different motivations, they're going to attack different systems, and they're going to perform those attacks in different ways than organizations who would be interested in harming patients. And so by allocating defense resources towards just one of those types, data, without consideration of the other type, which is patient health, attacks against patient health are in a situation where they're likely to be successful.
Okay. And when we talk about healthcare a lot, we talk about the privacy issue. Again, we go back to those records and HIPAA, and that's been a huge focus in the industry for many, many years. But you're saying we're actually talking about flesh and blood here. We're talking about potential harm to individuals, and that's what you found in your research, is that that's not being safeguarded at the level that it should be.
Right. So to make sure that we all understand the distinction between the two types of assets, patient data is, of course, the information about you, your medical record, whereas patient health is your vitals, your heartbeat, things like that. And systems that provide access to those two different types of assets don't always overlap, and actually in many cases there's not a strong overlap. And so what we found is that entities who might want to attack patient health would attack a system that really has no bearing on patient records, such as, for instance, an active medical device or passive medical devices. And by attacking those systems, you can hurt the patient, and any protection of patient data wouldn't really apply.
So give us some specifics. What are we talking about here? You identified specific attack surfaces of concern. Can you delve into that for us?
We sure did. In our report, we identified several different systems and actually walked the audience through the different attack anatomies. One example is one that I really like to highlight, is focused on passive medical devices. Because when you think about active medical devices, and those are devices that are doing something to the patient, examples would be something like a pacemaker, where it's actually manipulating your heartbeat. It's pretty logical to understand how if you attack that, that could hurt the patient. But what's less obvious is how an attack against a passive medical device, which isn't doing something to the patient, how could that result in harm? One of the examples that we highlighted in our research was the idea of attacking a patient monitor. Patient monitor, all it's doing is capturing data about the patient, their vital signs, things like that. What we found was that with the particular system we studied, an attacker could bypass authentication, and remotely execute code. When they were able to do that, that meant that the attacker could do one of two things. They could either activate false alarms or disable authentic alarms. So if you think about what that means, if you could activate a false alarm, let's think about a patient who's somehow incapacitated. Maybe they're under anesthesia on the operating table or they're in a coma. When that alarm goes off saying that they're in cardiac arrest, that patient is not going to be able to speak up for themselves and say, I'm okay, I don't know why that alarm's going off. Yeah. The responding care will follow a protocol, which will be to administer the electric paddles. Yeah. The attackers will then have thus weaponized the staff, because those paddles will deliver harm to that patient who doesn't need that.
So these scenarios, that you're laying out, they've got some pretty serious implications here. If I know the readers and viewers of CSO right now, they're thinking, oh, we haven't heard about this before. Is this just, a lot of scary stories that we're telling? What made you want to delve into this when it really is just sort of kind of what ifs at this point?
The motivation behind pursuing this research was that we went through a thought exercise of thinking, what's the worst possible thing that a hacker could do? If you rewind 2 years ago, what was dominating the headlines at that time was many of these retail breaches. And we said the story's bigger than credit cards. Mm-hmm. And pretty quickly we dialed in on the worst thing that an attacker could do would be to kill somebody. That day we started this research because what we wanted to identify was, is that the case? Could someone hurt people? And if so, what should we be doing about it? Some of the silver lining, I think, that came out of the research is that we were not able to find an example of where someone yet has actually performed an attack that has resulted in killing or hurting a patient. Mm-hmm. So that's certainly good news. But we also recognize that the complexity of the solution to this problem is going to take a long time to address. So what we're advocating is that the industry today start dealing with these problems, because it's not just possible, it's probable that this will happen. By being proactive, healthcare organizations can get out ahead of the problem and deal with it in advance.
Okay. And in this research, where are they falling short? Where are the areas that need to be addressed that you found in your research, and the reasons why some of these vulnerabilities exist?
Very good question. We identified a number of security vulnerabilities that were technical shortcomings. But we wanted to also investigate, why do those exist? So we spent a lot of energy investigating the business context of the healthcare industry and why are these issues present. And we found a very wide range of business shortcomings that the healthcare industry is challenged by. Some of those included things like insufficient funding for the security department. That one is probably not a huge surprise to anybody. But other things may be surprises, such as we found insufficient staffing in terms of both number of security professionals, as well as the type of security professionals, as well as the type of things those security professionals are doing. Mm-hmm. We found extensive lack of network awareness from an inventory perspective, from a logging and monitoring perspective. Aside from our security research, we found an extensive lack of security assessment or audit procedures. We found a lot of different types of software solutions that were either built by healthcare systems or built by third-party vendors that had never gone through any sort of security assessment, which is significant because if you're talking about systems that have implication on patient lives, they should probably be investigated for how they'll be attacked. From an implementation standpoint, beyond some of the design issues I just mentioned, we also found some pretty significant issues, including things like extensive use of default credentials. So for instance, one of the actual recommendations that is prevalent in the healthcare industry is the idea that many manufacturers of medical devices recommend to healthcare organizations to not change the default passwords. The reason for that is from a service standpoint. It makes it easier for the tech, who isn't going to know all the different passwords at different sites, to be able to perform their work quickly, efficiently, etc. Well, if all these systems are using default credentials are effectively publicly available information. Right. So that means that an attacker could use that information to access that machine and potentially cause some mayhem.
Right. Okay, some scary scenarios. But so before we close, were there plans or recommendations that you gave in the research, takeaways for hospitals and healthcare facilities based on this research on what they could do to try and get out ahead of the problem?
Absolutely. For us, it wasn't enough to just study the problem and say there's a problem. We really wanted to articulate the solution. So in addition to the findings that we found both at a technical level and a business level, we also published what we refer to as the blueprint. The blueprint is an actionable step-by-step guide that helps healthcare organizations of all sizes get from wherever they are today to a much more resilient point from a security standpoint. Mm-hmm. This blueprint helps organizations think through strategically the things that they need to do, whether it's how to think about their hierarchy. Do they need a security executive, and who should that security executive report to? Think about the types of training that they should be implementing. Thinking about how to segment networks. And it takes an organization through that entire process so they can arrive at a state of readiness so that they can deal with attacks as they come.
Great. Some really interesting findings, and certainly something that we'll be watching in the future then in the healthcare and the security space. So I want to thank Ted Harrington for joining us today. Thank you, Ted.
Thank you for having me.
And for more on healthcare security and the challenges facing the industry, check out other parts of CSO Online. That'll do it for us today. Thanks for watching.